change in the DAPSA score, both which showed significant changes over time out to month 30. Here's the change in baseline of the NAPSI, so the nail score in patients with a baseline NAPSI of greater than 0. And we're showing you the change on the y-axis again, similar. This is from the comparator trial that had adalimumab as an active comparator. And you can see that the results, although not, again, were very similar to what one saw with adalimumab. And we also see changes in OPAL beyond. We also see in the trial the measurement of the DLQI and the OPAL broadened trial on the left and beyond on the right. On the left, you have the active comparator not present, of course, in OPAL beyond. But once again, we see for the 5 BID dose, which is, of course, the one that was approved and we should be focusing on most, that there were significant improvement compared to placebo in both of these trials. So we've seen the efficacy. What about the vascular events? Let me come back here. One slide too far. Doesn't want to go there. These are the vascular events. Sorry about this. I don't know why it's jumping ahead on me.
Just doesn't want you to show the data, Chris.
I know, they're keeping me showing. Philip, your paper. This is also a paper by Philip Meese, where they looked at the vascular events from all phase 3 PSA trials. And you're seeing in E, which is the VTE, which includes DVT and pulmonary emboli. And they're really breaking this down by the entire cohort versus those patients who had cardiovascular risk factors in the cohort, or those who had VTE risk factors. And what you can see here is that those patients that either cardiovascular or VTE risk factors were more likely to develop a DVT or a pulmonary embolus. And then they did a similar analysis for arterial thrombotic events, again, looking at the whole cohort compared to those with cardiovascular risk factors and VTE risk factors, showing that it was those patients with the risk factors that had a higher incident ratio of developing an arterial thrombotic event. Now, this is not showing, if this is Philip Meese's paper, it doesn't show it got hid, but down below. But the important thing from the paper was that the incidence ratio of these events was higher in patients who had defined cardiovascular or VTE baseline risk factors. Philip is going to talk about the 1133 study in the next talk, which will highlight some other features associated with Tofacitinib and adverse events. So let's move on to Filgotinib clinical trials. This is a JAK1 inhibitor, and these are the data from the phase 2 EQUATOR trial in psoriatic arthritis. And I'm showing you up on the left-hand corner the proportion of patients who responded with the ACR20 with a placebo in blue, ACR15, ACR70. You can also see here the proportion of patients over time between week 0 and the primary endpoint of 16 weeks. And then you can see the ACR50 down in the lower left-hand corner. And then here we see the ACR70 with red, the active drug, and blue, the placebo. Over on the right-hand side, I'm showing you a variety of other outcome measures in this phase 2 trial. And this includes the change in the DAPSA score, as well as the proportion of patients that achieved the SARC response, and also MDA, minimal disease activity, the change in the PASDAS, as well as the PASI score, the skin score changes, and the change in the nail from baseline. So we see that there are multiple outcomes with this JAK1 inhibitor that were significantly improved with treatment. So this is a subgroup analysis from this trial. And so they took a predefined equator analysis to evaluate the consistency of response across relevant subpopulations. And you can see the key endpoints that they looked at. And they then broke this down to various categories, including gender or sex, BMI, disease, duration, severity, concurrent DMARDs, and prior exposure to anti-TNF agents. And from this analysis, they were able to demonstrate that the differences were consistently favored filgotinib across all the subgroups and reaching statistical significance in most of these subgroups. And no clinically relevant differences were observed across the subgroups. The other important finding, I thought, from this study was that there was a rapid and sustained reduction in inflammatory biomarkers. And so numerous biomarkers associated with clinical measures of PSA were noted to be markedly decreased, SED rate, CRP in particular. And several clusters were identified based on the rate and the magnitude of treatment response. Filgotinib significantly decreased these biomarkers associated with PSA disease activity. So an important finding that looks at things different than PROs and physical exam findings, but are truly acute phase reactants. Of course, the other important JAK inhibitor in terms of psoriatic disease is upadacitinib. And there have been 2 clinical trials published that deal with the efficacy of this medication. And there's the upadacitinib head-to-head trial, which is an active comparator, unlike with tofa. Actually, a real comparator, other than like an active comparator with the tofa trial I previously showed you, comparing outcomes between UPA and adalimumab. And you can see the primary endpoint here was at 12 weeks. You can see the 2 different doses of upadacitinib of 15 and 30 milligrams. I'd encourage you to focus on the 15 milligrams and the active, the medicine that they're really comparing against in terms of efficacy here is adalimumab in purple. And you can see here that there are numeric differences between both doses of UPA and adalimumab, but they are not significant. But it looks like they're pretty equivalent in this study. Similarly, the equivalency is across the other measures of the ACR50, although again, numerically, adalimumab was lower, and then the ACR70 shown over to the right. So an impressive comparison. We don't get a chance to see a lot of head-to-head data in psoriatic arthritis, although it's starting to happen more often. And this really helps in clinical decision-making to get an idea of how drugs are performing in a randomized trial. The placebo, of course, is shown in orange-yellow. So this is looking at patients achieving remission and low disease activity. This is the SELECT-PSA, which are patients that are non-biologic DMARD inadequate responders. And these are patients that are biologic DMARD inadequate responders. And you can see here, of course, the SELECT-PSA1 has the adalimumab in one of the arms looking at efficacy, whereas those patients who have been biologic DMARD prior exposed in the SELECT-PSA2 do not have that comparison because they've already been exposed and either had inadequate response to biologic. So here you can see various outcome measures, including MDA and again, I would focus on the UPA 15 milligrams in both trials. So 25% here, 16% at the primary outcome measure. Looking at VLDA, again, another measure of deeper response. And in the 15 milligrams, 25% lower in patients who were previously exposed to biologics, as well as VLDA, DAPSA, shown here. So across these measures of deeper response, there was observed within the 15 milligram dose reasonable numbers of patients who were able to achieve these outcomes at 12 and 24 weeks. So this slide breaks down those MDA components and allows you to see where patients were really responding. And you can see tender and swollen joint count, PASI, the PGA of pain, PGA of disease activity, HAQ, and the Leeds index. And what's really interesting, and here you have your 2 doses of tofa and adalimumab, was that what comes across to me in this slide is that the one area where you tend to see differences is with pain. That tends to be lower, and frequently a reason that they may not achieve the MDA measurement in those domains, and it comes across the board here. So pain over here, as well as you can see pain over here. Again, these agents can result in deeper remissions. Pain remains a domain that we are ever striving to improve our outcomes in psoriatic arthritis, and of course in other diseases like axial SpA and RA as well. Let's look at the skin for a moment. So this is an oral drug, and sometimes our expectations for skin responses aren't that high. But as you can see here, this is the PASI 75, PASI 90, and PASI 100. And this is showing you in the SELECT-2 trial that there is a significant achievement of important outcomes in psoriasis. Particularly look at the PASI 90 compared to the placebo and the PASI 100. So this is an agent that can have effects on psoriasis that are somewhat higher than what we've seen in oral drugs in the past. So I'm going to leave it there from my discussion of the JAKs in PSA, and I look forward to a lively discussion.
Thanks very much, Chris. You did raise the question about VTE during your discussion, and I thought it might be useful to just expand a little bit on that. So after the Baricitinib data for approval was presented to the FDA and the advisory committee for that drug, one of the things that came out at that discussion with the FDA was, is there a potential signal for VTE, meaning both venous as well as arterial thromboembolism with the JAK inhibitor class, because of some imbalance that was seen between Bari and placebo in that data set. So this became an item of interest, and Pfizer looked carefully at all of its clinical trial data. They also looked at the Corona database. They looked at the big registry in the United States. They also looked at something called the Truven database, which is a big insurance claim database. And in all of that data, they did not find a difference between Tofacitinib and placebo, both with the 5 or 10 milligram twice a day dose. So that was actually presented at a couple of meetings, and it was reassuring. But then what happened was that some data from what was called the 1133 trial came out. So the 1133 trial was a study that the FDA asked Pfizer to do upon approval of its drug of Tofacitinib for rheumatoid arthritis. And it was based partly on the observation that you could have lipid elevation with the JAK inhibitors. And so they wanted to have a trial in which patients were entered who were enriched to have cardiovascular problems. People who had angina, for example, or known coronary artery disease or known hypertension, were specifically enrolled in the trial, so a high-risk population. And they wanted to see, is there an imbalance between tofacitinib in either dose and TNF inhibitors in relation to heart attack or stroke? Well, about halfway through the trial, the Safety Monitoring Committee noticed that there appeared to be a higher rate of VTE in the 10 milligram twice a day dose, not in the 5 milligram twice a day dose, which is the approved dose for RA and psoriatic arthritis, but yes, in the 10 milligram dose. And the 5 milligram dose was similar to TNFs. And so that was called out, and that particular arm of the study was discontinued. And there were notifications that came out to practicing clinicians all over the world about this particular issue and the advisement to not use the 10 milligram dose twice a day if possible. And that really had mainly to do with the inflammatory bowel disease patients that were being treated with tofacitinib. That was an interesting observation, an important one that came out as part of a safety review of that study, but came out before the study was completed. Now the study has been completed over roughly 5,000 patients. And we have some press release information, but it's not yet published. So all I can say is that there appears to be a bit of a signal for cardiovascular disease or malignancy from the press release material that we have. And it's a little unclear. Is it there is some imbalance with a little bit more in the tofacitinib arm in comparison to TNF inhibitors. And what we don't know is whether this is because there is increased risk from the JAK inhibitor in this highly enriched population, or is it because the TNF inhibitor group had a slightly better outcome in terms of cardiovascular events. And so this still awaits deep analysis and publication before we understand it more fully. But I think this is something that we need to be aware of and talk to our patients about, and in particular, make sure that we're sticking with the lower dose of this 5 milligram twice a day dose of tofacitinib, and also especially looking at our patients that are very high risk for some of these events, like patients with antiphospholipid antibody syndrome, for example, or patients hospitalized with a fracture would be examples of people at risk for VTE.
Yeah, thank you, Philip. It's a great explanation of a complicated topic, but this has changed my practice and probably yours as well. So the JAK inhibitor tofacitinib can be very effective in both RA and PSA, particularly for the arthritis and PSA. But I have to I screen very carefully now for the events that you just talked about. So obviously VTE risk, cardiovascular risk, age are very important variables in my decision-making about whether or not to use a JAK inhibitor. Number one. Number two, I don't know, and nobody does yet, if this is going to cross the different JAK inhibitor classes. We need to see what's going to happen with that, that's critical. And also, I try and make sure that patients have been vaccinated for zoster before I start any of the try for almost any of the medications actually, but particularly in the JAK inhibitors. I wonder if that's something that's a practice you do as well.
Yes, absolutely. Chris, there's a question that's come in here. It's actually got two aspects to it. The question is, how soon after treatment begins can patients expect to see a response to JAK inhibitors in PSA? And for how long is the effect sustained?
So, having treated psoriatic arthritis for 30 years with a variety of different agents, what I've learned is that there is a wide variety of responses to any agent. I have patients, and I know you all do too, you start them on drug X and the next day they're I can't believe that I feel this great so quickly. And others, it takes 4 months. And I would say that thinking about JAK inhibitors in particular, that I think that I see responses within usually 6 to 8 weeks. I'm seeing something. Sometimes that's very dramatic and sometimes that's quite mild. Now I'm speaking particularly about the joints right now. The skin is a different issue. I tend not to use the current approved agents, JAK inhibitors in the United States for psoriasis, just because we have so many other effective therapies. But generally, I've been pretty pleased with the onset of action. In terms of duration of response, I have also been pleased with the duration. The patients that I have who respond to Tofacitinib tend to stay on it and find it to be very effective. Philip, do you have the same kind of experience?
I do, and particularly on that last point, one obvious comment to make is that since we don't have to worry about anti-drug antibodies the way we might with some of the biologics, this also makes for a longer duration of effect potentially. But it also brings us to another question, which is how about the issue of whether or not to use concomitant methotrexate? As you know, in the clinical trial, Broaden and Beyond, the FDA required for Pfizer to have patients on background CSD MARDs. This was partly because they weren't sure whether or not if the patient wasn't, whether there would be some progressive damage or whatnot. So so we don't have data from an actual RCT about not using it with methotrexate. Yet we know from registries like the Corona registry that many patients, that clinicians don't necessarily use background methotrexate. I'm curious what your thoughts are in that regard.
So my practice is if a patient's on methotrexate, I will, and I add Tofacitinib, I'll leave the methotrexate on for usually 8 to 10 weeks and discern their response to Tofa. And if they're having a good response, I will tend to taper, actually to stop the methotrexate. And I found that in majority of cases, I'm able to do that successfully. Now, obviously, from the point of view of monitoring, it really doesn't make a difference, right? You monitor them very similarly, but many patients really don't like taking 2 oral drugs if they don't have to. So I do try and see if I can make it a monotherapy situation.
Are there certain patients, Chris, that you find really do prefer having an oral medication as opposed to a injectable or infused medication?
Oh, absolutely. Definitely. There are a significant proportion of patients who really find that to be a major advantage, not having to inject themselves. So this is something that, when we're giving our patients the options of the giant toolbox that you've described many times, Philip, we do get patients to say, forget about the injectables. I want something that's oral. And now we have choices now in psoriatic arthritis of the orals, and I think that's marvelous.
Thank you so much, Chris. So it appears to be time for us to move on to the next section, if we could. Oops, I apologize. I've gone too far. My role here is to focus in on the patient-reported outcomes from these trials, and are there some special points to be made about some of these PROs? So to start with, I'm going to be commenting on the Tofacitinib trials that you've already described, Chris, and the first comment is on the HAQ score. As you know, it's the Health Assessment Questionnaire is a functional questionnaire that patients fill out about how well they're doing and ability to do things physically. And as we can see here, and this is not a surprise, there's significant improvement in the HAQ score with both 5 and 10 milligram twice a day doses. And there's even though this is not a head-to-head trial with adalimumab, there's comparability, so to speak, with the adalimumab data. So reassuring that these drugs work well in physical function. Then there comes the issue of pain, and you've already commented about this, Chris, and made the point that in the minimal disease activity goal that we have, one of the issues that we often face is patients don't necessarily have full response to pain improvement. There's so-called residual pain. And we know that not all pain that patients experience is due to inflammation in a peripheral joint. Some of it comes from central mechanisms. So we have a chronic inflammatory disease or chronic pain condition or certain psychological factors in the patient, as well as certain genetic factors that lead to this phenomenon we call central sensitization. And a subset of this phenomenon is what we call fibromyalgia. So we know that patients have increased neuropeptide expression in the central nervous system and increased sensitivity to pain, even when there's not much peripheral stimulation. And there have been interesting studies with Tofacitinib, with Baselin, where we see a very fast effect on pain improvement, sometimes as early as a week, even before some of the inflammation improves. And we think that there may be a direct central nervous system effect of some of these drugs on nociceptive input. And this is what the slide in front of us is a study in which this was studied further. And indeed, yes, there does appear to be some difference in impact, and not just on inflammation, on improvement of pain. A corollary to pain is in the psoriatic arthritis patient with psoriasis is itch. That's something that rheumatologists don't often ask about. Dermatologists do, because they know that in their patients with psoriasis, sometimes it's the itch that drives the patient mad. And they're scratching their scalp and their trunk and who knows where, and it can be very troublesome for the patient and keep them awake and disturb their sleep. And we do know from some interesting skin biopsy studies that the skin is rich with neuronal input, and that there is crosstalk between neuronal fibers and synapses, as well as some of the immunologic cytokines that are active. And this is a very rich area of research at the moment. But needless to say, a goal we're looking for with some of these agents, and we see this with the JAK inhibitors, is improvement of itch. Turning to Filgotinib, let's take a little bit look at the data here. It's very similar data in terms of improvement with the HAQ score and pain. Here we're showing again, and you can see as early as 1 week, as I mentioned before, the improvement in pain score. And on the left-hand side, we're seeing a bar graph where we're seeing at least 30% improvement in pain response, which is considered a minimal clinically important difference in the majority of patients. And then in a slightly lower number of patients, but still very significant, a major improvement, which is 50% improvement of pain. So we're really making good strides with the JAK inhibitors in ability to control pain. Turning now to Upadacitinib, we're looking at the SELECT-PSA 2 study, which is the patients who had previous biologic exposure. And we're looking at the skin changes. And on the left-hand side, we're seeing improvement in something called the Static Investigator Global. And Chris, you've already shown us the PASI score responses with Upadacitinib, which, as you mentioned, were slightly higher than what we've seen with some of the other JAK inhibitors. And then on the right-hand side, we're seeing utilization of a brand new patient-reported outcome assessment of psoriasis known as the SAPS score, and showing improvement of that, which is highly correlated with the more objective investigator global assessment on the left-hand side of this slide. So we're now seeing patient-reported outcome measures that are validated being used to assess psoriasis. And I'm hoping that we're going to start to see this used in clinical practice as well. It's sure going to make it a little bit easier for us than, say, using a PASI score. Here we're looking at fatigue and using an instrument known as the FACIT-F. This is a multi-dimensional questionnaire about fatigue that was developed by David Cella from Northwestern University. And he did a lot of work on and crafting this particular measure, which is used in many different diseases, oncology, rheumatology, et cetera, and has been validated. And again, we're seeing a significant improvement with JAK inhibition here, that using the Upadacitinib. This has led, one of the things that we're expecting when we are looking for approval of this drug in July is that improvement of fatigue may be part of the FDA-approved indication. The FDA is now getting the fact that patients really consider fatigue to be an important issue for them just as much or almost as much as pain. In many of the focus groups that I am aware of with patients, they rank this second after pain. Some of it is due to the cytokine activation in the central nervous system that leads to the phenomenon of fatigue. Some of it's related to other factors like sleep deprivation or depression, but nonetheless, a very important outcome. And it appears that the drug not only improves fatigue through reduction of inflammation, but also potentially direct CNS effects. And now with Upadacitinib in the SELECT-PSA 2 study, we're seeing results in other patient-reported outcome measures such as the HAQ score, the SF-36, both physical component summary, which is a quality of life measure, and in the fatigue score, as mentioned. Lastly, I'd like to speak about a new drug that isn't yet in the clinical domain called Deucravacitinib. Boy, some of these names, I tell you. So this is a fascinating drug that is being developed by BMS, and it is a TYK2, TYK2 inhibitor, which is part of the JAK inhibitor family. And the drug binds to the so-called pseudokinase domain, which is different than the typical ATP binding active site that other JAK inhibitors bind to. And this makes the drug extremely specific for TYK2. There's no crossover into, for example, JAK1 or JAK2/3 inhibition. One of the things that this drug will do as through the TYK2 pathways, thinking back to the slide that Chris showed at the beginning on the various cytokines that are regulated, is that it diminishes interleukin-23, which we know is very important in psoriasis and psoriatic arthritis. So this drug is being developed not only for PSA, but also for psoriasis. It's none of the other JAKs that have been introduced thus far are being specifically targeted for psoriasis. Here we're showing the PRO of HAQ score, the physical function score, showing good benefit from Deucravacitinib in this phase 2 study that was recently presented. Here we're seeing the quality of life measures, both the physical component as well as the mental component summary. And then again, the same outcome measure, the multidimensional FACIT-F, which is showing improvement. Sorry that the font is not great here, but take my word for it that it shows improvement in both of the doses of Deucravacitinib that was used. And then there's a very interesting approach taken in this pure psoriasis trial with Deucravacitinib. This is one that Kim Papp published in the New England Journal and showed highly significant efficacy in the skin responses of psoriasis, PASI 75 scores up in the 65% range. But one of the things that they did in this study was to ask the investigator, do you think that this patient has psoriatic arthritis? And so this is the subgroup, about 30% in that study, that had musculoskeletal symptoms felt to be consistent with PSA. It wasn't a formal study of PSA. It was just simply to try to get a look and see. And what we saw was meaningful improvement, statistically significant improvement in pain, rapid and improvement. So this was an effort to get kind of a signal from a psoriasis trial about what a PSA response might be. Wasn't perfect because we didn't have things like joint counts and so forth and to really confirm about psoriatic arthritis, but I applaud the effort to try to get some data from psoriasis trials about some of the PSA domains. So with that, I will bring us back, Chris, open it up for discussion after having reviewed the important issue of patient-reported outcome measures with the various JAK inhibitors.
Thanks, Philip. That was really very informative and clear presentation. I have a couple of questions, and we've got the audience has many questions. The first is there a correlation between lack of response and lack of improvement in fatigue, as we see with pain in psoriatic arthritis?
Right. So one of the studies that's going to be presented at the upcoming EULAR meeting is one of these interesting path analyses or mediation analyses, they're called, in which you use it's a difficultly done statistical methodology where you try to sort out how much of this particular phenomenon, in this case fatigue, is due to inflammation versus other and particularly direct central nervous system factors. And the take-home message from this upcoming abstract is that the answer is yes, that it's not all subsumed under the issue of inflammation. And there are some central nervous system factors, including central sensitization, that are contributing. And so we're going to be seeing more of this, I think, in the future, where we're looking to see if our drugs have effects beyond specific immunomodulation, but actually may have some neuromodulation related to their effectiveness.
Thank you. I think this also drives home the point of how important it is to think beyond inflammation, not only as an etiology for your patient's non-response or inadequate response, but thinking about alternative additional therapeutic modalities that rheumatologists should really, if they're not already, many are obviously, but need to incorporate into the therapeutic regimen, right?
So are you thinking of medicines like the selective serotonin and norepinephrine reuptake inhibitors like duloxetine, or what are you
I'm thinking more broadly. I mean, I'm thinking even of, obviously, and you and I have talked about this many times, addressing other issues such as making sure they're not having sleep apnea, exercise in patients that are very heavy, the weight loss. I mean, I think there's a number of factors that can lead to adding to pain and fatigue that will not be directly addressed by the current therapies, and we need to think about those, especially in our patients that are having inadequate responses.
And Chris, I know that in your multi-dimensional unit at Rochester, haven't you had a psychiatrist involved or a psychologist involved at times? Yes.
Yeah, we have one in our clinic with us, and what's really interesting is that there are patients. I've actually never seen a patient, so she'll come in the room with us, and after we interview them and make a plan, she'll stay behind, and even patients who I thought would no way would they want to talk to her, they're welcoming, and they really enjoy the opportunity to describe the emotional problems that they've encountered in dealing with this disease. It's been really quite enlightening. So yes, and we know that this can be devastating in patients in so many ways. Now, Philip, the other thing I want to ask you, I was really interested in, you're talking about pain. We're both interested in that, of course, and the pain receptors. And one of the papers that came out from in the Journal of Clinical Investigation several years ago was a study by Rijo Blanco, where they showed in the mouse models that the nociceptors in the skin, that when they're activated, they actually can lead to the release of IL-23 from dendritic cells that are tethered to the other end of the nociceptor. So, it really brings in this interaction between the nervous system and immunologic pathways that I think we're now only beginning to understand, right?
Perfect. Yes, that's exactly what I was referring to earlier with the research that's showing this interesting crosstalk between neuronal pathways and immunologic pathways, and I think this is a sort of frontier area that we're going to be learning more about.
Very exciting. So I have a question for you from one member of the audience. Is there any explanation as to why JAK inhibitors are a bit numerically stronger in alleviating pain in RA, and using the example of BARI and UPA versus ADA, but not so much in psoriatic arthritis?
So do I.
That's for you to answer.
So I was gonna push back a little bit and say I'm not sure that I know that that's the case, because as I obviously treat both RA patients and PSA patients and have had them in trials with the JAK inhibitors, and my observation is that they generally are very similar in their responses, and whether or not there's any impact of some of the other factors, like even skin of pain from psoriasis, that might be an addition, could be. But I know, I think that that overall the data that I'm seeing is that they're pretty they're highly effective across the board with not only RA and PSA, but also, as we'll soon see as we get these approvals for Tofacitinib and Upadacitinib for HAQ-SPA coming out very soon, in that condition as well.
Great. Philip, given these interesting results from clinical trials, shall we expect an update in the PSA guidelines in the position of JAKs in management?
Yes. So certainly in the upcoming GRAPPA update, which you and I are involved in, and Laura Coates will be presenting at the upcoming EULAR meeting, the JAK inhibitors will be incorporated in that update, and we'll see in all of the clinical domains that are represented in that in the GRAPPA treatment guidelines that the JAKs are going to be recommended. And so I think that that's important. And we've already seen them recommended in the EULAR guidelines. And as you know from the ACR guideline work that we worked on together, that they although the data wasn't published yet, Jaz Singh knew that it was important to include that as well in the ACR guidelines. So yes, and especially now that we're seeing more and more JAKs coming along, like the TYK2 inhibitor that I mentioned, Deucravacitinib. There's one from Pfizer that's a TYK2 JAK1 inhibitor that's coming. This will be an important class to include in the recommendations.
Agreed. What are your overall thoughts on efficacy and safety of UPA versus TOFA for PSA and AS?
So that's a slightly provocative question, because we don't have any head-to-head data, which would be the most reliable way of responding to the question. I think that we're seeing some interesting subtle differences, or not so subtle. For example, you presented, Chris, the data on skin disease. I also presented the PRO on skin disease with UPA. And at least numerically, the responses are a little bit higher than what we have seen with Tofa. But keep in mind that it's difficult to make such a comment with reliability because these are different patient groups, and so I hesitate to make much out of that without head-to-head. In terms of safety, that's also sort of is difficult to respond to because when we look at the clinical trials alone, the data, as well as some of the registries like the Corona registry and so forth, the data with regarding safety is pretty similar across the JAK class. It's really mainly this 1133 study with Tofa that has upended us a bit, and that was a select, very high-risk population. So it's a bit of an outlier. There's recently been published from DAPSA, and Mike Weinblatt was part of this analysis of a market scan data, Medicare, Optum databases. It looked like there was pretty much similarity between Tofa and the TNF inhibitors in terms of some of the outcomes that were looked not quite as good in the 1133 study. So I think that other than the 1133, my sense is that the safety is going to be fairly comparable between the drugs, with zoster, as you've pointed out earlier, being an issue that we see in higher rates. With the JAK inhibitors, we have to, of course, be aware of the potential for serious bacterial infection and malignancy, and so on. We need to monitor for elevated lipids and elevated LFTs or drop in blood counts. So I think our surveillance and for all of these safety issues is going to have to be pretty similar with all the JAKs.
Yes, I agree. This one's directed, I think I'll answer this one. Having discussed the IL-23/17 axis as a reasonable target to treat PSA and AS, is there an idea why inhibition of IL-23 is not efficacious in AS as IL-17 and JAK inhibitors are? Well, there's two current hypotheses about that. The first is that interleukin-23 is very important in the early phase of ankylosing spondylitis, axial SpA, and that as the disease progresses, it's not critical in the persistence of inflammation. That it is sort of the cytokine at the top of the building that's directing events downstream later on, and not itself key in persistence. This is coming from an animal model that was published by Yeremenko and showed that to be true. The other very, I think, dominant hypothesis is that there are a number of innate immune cells that can release IL-17 in the absence of IL-23. So IL-23 independent IL-17 production is present. How much of that is responsible for the lack of response is something that we don't know. I'm looking forward to trials in axial SpA, a very early disease with IL-23 inhibition, in order to test that first hypothesis. Philip, do you have anything else to add on that?
No, I think other than the fact that you're absolutely right, there are some fascinating apparent differences between IL-23, IL-17, and TNF in the spine, and we're trying to sort out, is this specifically related to axial spondyloarthritis? Does it also extend to axial PSA? Or is axial PSA enough of a different disease that we might expect to see some better results with IL-23s? We really need to have axial PSA specific studies coming along, which there are, to really tell how well the IL-23s work in that aspect. Chris, I'm seeing a question here, which I'll direct to you. A question about the JAK inhibitor effects in PSA related to extra-articular manifestations such as IBD, uveitis. She also mentioned psoriasis, although we've covered that. But I'm particularly curious about your observations about whether or not JAK inhibitors might be useful in IBD and in your patients where it's a coexisting problem? What are your thoughts about it?
Yeah, it's a fascinating question. And we know that tofa is effective in ulcerative colitis, it's approved for that, but not in Crohn's disease. And I'm baffled by that divergence, but it's a reality. In terms of uveitis, that's another fascinating question, where it turns out that IL-17 inhibition IL-17A inhibition doesn't seem to be effective in uveitis. I'm really eager to find out what IL-23 inhibition does in uveitis, and in terms of a better understanding of how the various JAK inhibitors are working in the uveal tract. And to my knowledge, we don't yet have that data. The other interesting question that came up that is related about psoriasis is why is there an easy explanation as to why the JAKs you discussed seem efficacious in PSA, but only a select few seem to show high efficacy in the skin? I'm sure, Philip, you have some thoughts on this. I know that my thoughts range from, well, first of all, tofa did show more efficacy in the skin at the higher dose, a 10 BID dose for sure. That wasn't seen at 5 BID, number one. Number two, we know that the JAK1 inhibitor UPA shows pretty high efficacy in skin. And my explanation for that is that it's targeting interferon pathways, JAK1, which are downstream of the interferon pathways, and that these are very important in psoriasis. And then lastly, Philip beautifully covered Deucra, which is a TYK2 inhibitor, and we know that's very effective in psoriasis. So I think in terms of the JAK inhibitors in skin disease, it depends on which JAK you're inhibiting may determine how effective the agent is. Philip, what are your thoughts?
Exactly. I agree with you. I think I agree about the UPA being a little bit more effective than with some of the other JAKs, and then specifically the new TYK2s being even more effective. So I think it depends a little bit on which aspect of the JAK inhibition effect you dial in or out as we customize the JAK class. There's one question here, Chris, which I can address.
Sure.
Is the VTE risk and effect related with JAK-I doses or a class effect? So the first comment I would make is that we haven't really seen a striking signal for VTE with UPA. We haven't with Filgotinib. We haven't yet with Deucra, although it's early days yet with that medication. As mentioned, there was a little bit of a signal with the Baselin data, and now with the Tofacitinib higher dose. So at least from the 1133 trial, we could say that at least for the pan-JAK inhibitors, it looks like it may be a dose effect. Whether or not more selectivity, such as being a more purely selective JAK1, helps reduce the issue, that remains to be seen over longer observations over time.
Very quickly, there's a question about nail disease and JAK inhibitors. I did present nail data from the TOFA study, and there are nail data out there. We don't have time to go into them, but you can find them in publications. So, Philip, it has been a true pleasure as always.
Yes.
Co-chairing this with you and getting a chance to talk about a subject that's very close to our hearts. And we really appreciate the questions and the interaction here. It really makes it so much more fun and educational and entertaining. And this is an exciting sphere that we're all involved with in psoriatic arthritis and AXPA. And we look forward to many more seminars like this and advances that are going to happen in the next year. Right, Philip?
Yes. Thanks so much, Chris. It was great collaborating with you on this presentation. Thanks so much.
And thanks to CSF for sponsoring this. And everyone have a great day.